Hi, guys. So we are here bringing now our experience in treating these complications after lipolaser. So in Brazil, suddenly the lipolaser devices to assist liposuction became very popular. And we are going to show a study that we just published about that. You know that in Brazil we have this big problem. Was a study we published when I was the president of our local society in my session in Minas Gerais state. We gathered multiple presidents of dermatology sessions in all throughout Brazil. And we interviewed actually 1,058 doctors. We did a study with them, dermatologists, infectious diseases doctors, and also plastic surgeons. And we wanted to actually to see the impact of unlawful aesthetic practices in Brazil. This was multi-center study. And this slice of the pizza is actually the amount of patients that arrive in our offices that have already undergone procedures with, non-physicians, invasive procedures, including liposuctions. And these are the artists. So some of the dentists now in Brazil, they call themselves, they advertise themselves as dentists of the skin, which is nonsense. But that's, that's everybody, trying to practice medicine. And so I'm going to show you some of the cases that were actually, the aim of our study, what actually has driven us to do this study. So the first one is this patient with retractile hypertrophic scars on lateral face. She was actually going to have the wedding of her son, and she wanted to do something to look better, but she didn't have time to do a surgery. So Morpheus was offered for her, and she did both the radio frequency needles and the face tight. And she said that after 3 days, she began to feel a very bad pain, followed by erythema, blisters, infection, fever. She had to be hospitalized to a burn unit referral, and she had abscesses with drainage. It required a week of hospitalization and several dressings, and developed progressive retraction. That's when she looked for care in my office. And so this is what it looked like. She had these 3 main areas of retractile scars. At some point, they looked like keloids because this neck lesion started to grow beyond the boundaries of the initial wound. And that's when she became very, concerned. And this is the other patient that had this hypertrophic scar with some areas that actually looked like keloids, with some retraction following a liposuction procedure. So again, in the 3rd postoperative day, she referred necrosis, erythema, blisters, edema. She mentioned on Renuvion, but some of those patients are not even informed about what has actually, been used as a technology device associated to liposuction. And this is how she looked like. She's a young lady. And this is her photo right after, when she had the complications. So necrosis, erythema, blisters, edema, infection, abscesses, followed by drainage. And this is another case, a similar one, not as bad outcome, with retractile hypertrophic scars on lateral abdominal wall, following liposuction, intense postoperative pain, followed by erythema, skin necrosis, and infection. Required debridement and evolved with hypertrophic and atrophic scars. Another case, a similar case here. And this was a patient that actually was treated with probably Renuvion. She was not also sure about that, who developed not keloids, but fibrotic achromic scars following liposuction. And this is actually a celebrity fashion star in Brazil. She has actually stores of clothing all over the world, including Dubai, New York. And she's a model for her own, dresses. And she dresses misses, all the way. And she was very unhappy with the results of a liposuction, what it was offered to do Morpheus. And she developed these hypopigmented scars on her body. And this is on her thighs. So she actually had complications all around. And this bizarre aspect of, squared-like marks following the tapes that were used by the physical therapists right after the body tight device. And this is another patient that developed unilateral deep fibrosis 2.5 months after surgery, and she was seeing that it was worsening over time. So that's when she came, to look for treatment. She had retraction, lowering the lateral commissure of the lip, following neck lift and lower lip lift. So how to manage? So this is actually the study that was actually the beginning of how we think on treating these patients with keloids and scars. This was a study where we actually compared silicone and non-silicone gel dressings. And we found out that it was not exactly silicone, but it was prolonged occlusion that would, bring some results in decreasing some of the physical symptoms of keloids and hypertrophic scars. Because that study was commented by the New England, I had a chance to, to go to do a postdoc fellowship at Shriners, where we've studied some of the other features, especially regarding molecular and cellular aspects of scars and keloids, and a couple of studies here, and also developing some tools to measure scars. And working also in some of the features regarding histochemistry. This is type 4 collagen marker in normal scar and very hypertrophic scar, and those were also with types 1 and 3 collagens. They look like almost the same in both scars that are very hypertrophic or keloids, that we couldn't find any differences when we compared both. So we have this method developed that we have a couple of publications now talking about it, and it's been recently revisited. I think my student has shown it yesterday. It's called ASAP. And we can use it both for prevention and treatment of keloids and hypertrophic scars. And we've actually had the chance to look at a very long, term of evaluation in patients that were treated many years ago, like 10 years ago, in a study where we called back 79 keloids and that were treated many years ago, to assess them, to see the recurrence rates. So I'm just going to show you some of the results, and this is what our algorithm stands for. It was actually written to our residents, so it aimed to be very didactic for them to learn. Actually, this algorithm was designed to avoid that our residents would just think on triamcinolone injections in the first, bad outcome or scar or keloid that arise in front of them. And so A stands for assessment, and then we soften the lesion using, prolonged occlusion. We approach it using a combination of lasers and injectables, and finally we treat pigmentation. So during the assessment, we actually try to be very careful evaluating those patients using photographs. We use the durometer that I'm going to talk about it a little later. We try to assess the skin type to see how prone that patient is to do hyperpigmentation, especially post-laser hyperpigmentation. We are now using a lot of ultrasound to look at the thickness of those lesions, and we've been using a lot of the photo finder to assess the vascularity. And one device that we've been using more and more is the LLT, that stands for lower level laser therapy, that does photobiomodulation. We were quite skeptical about it, but going out in different forums regarding the treatment of scars and keloids, we've seen that most people were using it, and we suspect that it's being able to actually decrease the inflammation following our procedures. And so we'll start by softening the lesions, and hopefully we are using this method to actually be added beneath underneath the pressure garments, and it helps to actually adapt to the keloid and help compression. So we combine pressure garments and occlusion using the dress ends. And we also manufacture the garments according to the patient's needs. And so the idea here is actually to shrink the lesion before you start injecting it. Dr. Tirgan thinks it's not necessary, but we are so used to do that, and we think it helps a lot. And this is how our patient actually leaves the office. And she's going to keep the dressings for like 15 days or sometimes a week. This is with silicone dressings, and the, hydrocolloid dressing could also be used. And this is after 3 months, 3 sessions of, using the dressings and doing the IPL followed by the 5FU, just 0.3 ml of 9-to-1 5FU to triamcinolone. So it's really, really very low doses and that we actually inject. It's not necessary to inject a lot because the keloid is so soft that, a little bit of the drug will diffuse throughout the lesion, and we can actually see in some of the cases that it's, it becomes blanched, right after you inject it. And this is after 4 months of treatment. I don't have her final outcome, but she's completely improved. And sometimes we know that the patient is going to need, like for this one, tissue expanders and also surgery. But even though the plastic surgeons are referring the patients to us to avoid operating on lesions that are very thick. So we try actually to smooth that lesion, to make it thinner, and so it's going to be much easier for the plastic surgeon to do the surgery. And let's see if we have the hair. Okay, so and so we go to the third letter of our protocol, which is A, of approach. And we approach those lesions using a combination of lasers and injectables. So here you're seeing that we are doing 3 technologies in the same sessions. We are doing the pico laser that we are already assessing and treating a little bit the hyperpigmentation. Then we are doing IPL to, to approach the more superficial vascularity. And finally, we are doing the long pulse Nd:YAG 1064 to assess a little deeper vessels. And we are injecting, and I wanted to show you that it's not necessary really to inject very high dosages. Just, I use a 0.3 ml syringe that I use also for Botox injections. And you don't need to do any, strength at all because the lesion is already very soft. And let's just see, okay, we are going to have another lecture later talking about lasers. But anyway, just to show you that when the lesion is too red, you need to use lower, shortened wavelengths, while when the lesion is too purplish, you can go deeper, increasing the IPL wavelength. And so this is the same session and some of the things. Now, for this patient, she used occlusion 24/7, LLT once a week, IPL 1 session. So this is the difference of 3 to 4 weeks. You can see that it improves a lot the fibrosis. It starts to detach the lesion from deeper planes. And this is our patient after the tissue expander, after the scar was almost atrophic. And some other cases here. And finally, we treat pigmentation. And for pigmentation, we combine all of these techniques, topical depigmenting agents, peelings, the pico laser, I've been using it more and more, IPL, especially the 640 nanometers that go a little deeper, but also improve better the pigmentation. And I also like to combine CO2, pico, fractional pico, and erbium lasers. So this is the pico working in a pigmented scar. And this was the treatment used for this patient to improve the hypopigmented, scars after microneedling radiofrequency. Very simple. This actually, when I treated that patient, I still didn't have the picoseconds, just the nanoseconds. And I'm seeing a big difference among those two technologies. But anyway, this is after one session of the nanosecond lasers, followed by a retinoic acid pill. And something that we also do is to combine something we call MMP, which is a technique that uses a tattoo machine. And this was with bleomycin just to repigment the scar. And this is one session, you can get it completely repigmented because bleomycin brings all the pigmentation back. And it's really just a drop of bleomycin. It's really, really, really very, very, very small dosages. So, and here it's basically what I'm doing is actually detaching the scar using something we call tunnelization. When the lesion is too atrophic, it's usually, attached to deeper planes. And after that, I am doing some sculpture injections, just a little tiny bit in the body dilution. And finally, the tattoo machine, you can use also saline solution, you can use also 5-FU. The three, things are gonna bring the pigmentation back. This is the original study of one of my master's students that already finished, dermatologist from the north of Brazil called Dr. Luciana Gasquez, a very bright student. I'm very lucky with my students, all very, enthusiastic. This was actually the pilot study. We used to actually assess the size of the sample that we would need. And now her final study had 25 patients treated with both 5-FU or physiologic saline solution. Actually, the physiologic saline solution did better because the 5-FU patients pigmented more. They had more hyperpigmented pigmentation at the end. But anyway, it's in JAD, so we are like this. Hopefully it's going to get accepted. They requested for a minor reviews. And I presented this in the last SCAR meeting in Milan. And this is one of the patients of our liposuction study. It was after argoplasma. She developed all of these, very bad scarring with, a lot of pain and retraction, things that we cannot see by the photograph. But she was very bothered, and with all of these spots, there are actually hemosideroses mostly. And so we did this combination approach. We used occlusive dressing for 2 weeks. Then the lesion was already soft, and we started with the picosecond lasers. And I'm having these results that like I said, I didn't have them before when I used the nanosecond. So if you guys have a nanosecond laser, I really advise you to exchange it for a picosecond lasers. And this is the study that we've published just a few 2 or 3 months ago, and we'll be very glad to, to share. And this is my group, and I always like to, I added them using ChatGPT to the Harry Potter castle, but it's just because I think it's important to mention that all of our studies are, after a big group, everybody thinking together and studying and doing different approaches. So I'm very happy with my, research group. We are 30 researchers right now. No funding, but a lot of enthusiasm. Thank you. The team, you? They are clapping to my study group, my students. They did most of the work, actually. Yes.
Questions?
Yes, tacrolimus, topical tacrolimus. Yes, yes, topical tacrolimus, it's used to treat like vitiligo in the very thin skin. and we use it after when we are trying to repigment a scar. We use the MMP, which is this technique of microneedling, but then in the intervals, the patient is using tacrolimus in their houses. And, you have commercially available, like, in Brazil, there are a couple of those, and I think in the U.S., maybe Elidel, is there a U.S. dermatologist? I don't know. In Europe, what tacrolimus do you have? Topicals. There's plenty of topical tacrolimus. It's just a cream you can use, the moisturizer.
Yeah, in vitiligo, of course, it's an autoimmune disorder, so it suppresses the inflammation. So, and it typically with 800 Dalton, it doesn't penetrate very well through thick skin. So in the face, it's very good. On the body, often not so much. So I wonder really, I don't know.
You have actually to combine a lot of things, and we use it, and we think it helps, especially when the lesion is very flat already, and there is no fibrosis. Yes, of course.
Sorry.
Who do you think is causing these problems?
For the plastic surgeons, but also in Brazil, unfortunately, some of those cases are after the practice of medicine, I think very invasive actually procedures by people that are not qualified. So it's a very unfortunate thing. But there are other problems too. For instance, some of those devices are not FDA cleared, not, Anvisa, which is our FDA equivalent. So a couple of other things too. And they are being fully commercialized, even in big meetings that we go, even when they are not, cleared by the regulatory places. But what we've seen because we did also a systematic review in this study, and it was difficult to convince the editors that we wanted to add the case reports together with the systematic review, because we think it would bring some attention to the problem. We believe that there is a lot more advertised about those machines to assess, to help liposuction that they actually do. And at least not as many studies as we should have.
Well,
do you disagree?
You know
but
who
please.
is Ivo Pitangui, right?
Huh?
You know who is Ivo?
I know, yes, sure.
So he, 20 years ago, predicted exactly this. When the internet comes, now everybody's going to advertise, and people, they take a course of liposuction for a session like this and start doing, and nobody controls that. Now it's getting out of hand in other countries more than in the US, because in the US they put to jail somebody's doing this, okay?
Yes.
So this is very unfortunate, but I think
it's difficult, and it's happening everywhere. And this study, it has very few months of publication. The unlawful practices, we published it in dermatologic surgery, and it brought a lot of attention. It has already 8 citations in very few months, and we are doing the international branch of this study now, with colleagues from the US, from India, from different parts of the world. Ophir Arts is doing the part in. We are working on that to do. There's somebody in Italy, Israel, and we think it's a worldwide problem. But of course, some countries are less regulated, for sure.
I congratulate you. You're doing great work.
Thank you very much. And you know that I used to be a surgeon before I was to dermatology. My first residence was surgery, and I received Dr. Pitangui many times in our university. Yeah. Our professor, the chief professor of surgery, was his close friend, and he used to come and give us, the main lecture of the meeting, like the keynote speaker. I've seen him talking about that. Thank you.
Thank you. I think we have to move on.
Yes.
It's you again.
Okay.
Please.
I'll be very fast with this one. So, oh, it's not going through. Should I do something here? It's not. Yes, it's the new one, but it's not. You see, it's not going. Maybe you have to do some. No, it's not. It's already in the computer, remember? Maybe you have to, you want me? Okay, so we are using the ASAP method for several years now. I have this big clinic. I also work in a public ambulatory. I'm at the university with the residents as well. So a lot of patients being treated with that. And a couple of, like 2 years ago, I received a patient that is actually a young vascular surgeon, very beautiful. And she said, Gisele, can I have sculpture on my face? And I said, a sculpture is a biostimulator. And I said, why wouldn't you? Do you have any autoimmune diseases? And she said, no. I was a patient of yours treated for acne keloidalis many years ago when I was 16 years old. And that means first that I'm getting very old. I have my patients that were treated like 20 years ago. But when she removed her T-shirt, we couldn't see any spots on her acne keloidalis, and we saw her pictures before, and this is just an animation because she didn't want us to use her photograph. But anyway, she said, you know what, you should assess those patients. You have to call them back. And we've got it approved as a retrospective study, approved that our IRB, and we came out with this study. We actually called back. We had a lot of patients in our charts, but we could just get 79 keloids to come back, patients that were treated several years ago. And we did this study that was also, I think, a PhD study of Marina Patrus, another student of ours, and master's student. And so we called those patients back, and we wanted actually to assess those keloids that were treated with the ASAP several years ago. And so we had 79 keloids. Those were, the main areas of the keloids. Most of them were women. We think women come more often. They are more bothered with the aesthetic outcomes of the keloids. And those were the factors leading to the development of keloids. So all sorts of, different topography of the lesions. And we actually assessed everything. We had everything written in our charts. The patients were all treated with the ASAP. We didn't use any lasers at that point, just IPL. So all of them were treated with IPL. We saw that the median time of treatment was 10 months, no significant association between keloid location and recurrence, complete resolution, adverse effects, or treatment duration. We actually seen that we had higher satisfaction rates that were positively associated with complete keloid resolution, of course, and significant lower results in complete keloid resolution in patients who had adverse effects pain, probably because they didn't want to complete until the final outcomes, until we asked them to stop. So when they achieved something that they found it was okay, they stopped treating. We observed that adverse effects retrieved significant association results, lower likelihood of complete keloid resolution by linear regression analysis, and higher satisfaction rates were positively associated with complete keloid resolution by multivariate logistic regression model. And we also have seen the influence of several potential effect modulators on treatment duration. Now, I want to call your attention for one of those. It's that all our patients that received the steroid injections before they started our treatment, more than a year before, because this was one of the inclusion criteria, the exclusion criteria, the patient had stopped triamcinolone injections at least 1 year before they did our treatment. So all of those patients had a worse response. It means they took longer to respond. And we had some ideas about that we can discuss later. We had very, very low recurrence rates, and these are some of the lesions treated. So just to show you some of our publications regarding that treatment before. And this is our ASAP, complete revisited algorithm. And I've already shown you that we try to assess in the first day how what exactly is the lesion, if it's a keloid, if it's a hypertrophic scar. We try to see if the patient is prone to post-inflammatory hyperpigmentation. This is a very simple method published by our colleague Hector Leal from Mexico, to assess how prone the patient is to hyperpigment after a laser session, especially. This is our study regarding, how to assess vascularity for those lesions. We are using more and more the photo finder to see our endpoint of our vascular lasers. And this is a very simple device called durometer. Durometer was actually in a couple of studies of NASA. And when I was in Shriners, Dr. Hendon asked us to get all of the Vancouver scar scale subjective assessments replaced by objective measurements. So in the final, outcomes, we actually seen that the durometer was the single device that were most reliable and mostly associated, directly associated with the overall Vancouver scale. So you can actually almost replace the whole Vancouver scale by the durometer. And it actually shows you how harder the skin is and the scar is compared to the normal skin. And then we soften, I've shown you, and this is the outcome we want before we start injecting our keloids. We want them to be this soft, so we think it's much easier and less painful to inject them. And we have some special studies showing how to properly occlude the lesions. But one thing that I want to mention is that the occlusion needs actually to perpass all of the keloid or scar. It cannot be put just on top of the scar or the keloid. It has to go throughout the scar for at least 1 centimeter, we think. And this is another study where we've shown how to use the hydrocolloid resins. And this is how our patient actually leaves my office. And so, and this is just occlusion. You see that the lesion starts to shrink. I've already shown you the approach with lasers. And we have to think on what device we are going to use and what are the drugs. So those are the drugs that we are mostly using in our practice now. Now what I try to do is to do different sessions using different drugs. All of them I always associate with triamcinolone, except by the day when they come to do the botulinum toxin that we've been using more and more. So this is a patient that had 2 different treatments. He had cryotherapy plus injections of triamcinolone, and he had also surgery plus radiotherapy following keloid after autoplasty, and that's after we treated him with the ASAP. I've shown you this, and just the reason for starting with vascular lasers is just because the lesions are all so vascularized, and we've shown it in different studies that I will be very glad to share if you want. And this is a month after month treatment of a scar. It's not exactly a keloid, using the vascular laser. So you can see that the lesion turns from red to purple. And that means that we are stopping seeing vessels that are so much in the surface, and we are starting to see vessels that are deeper. So they give this third photo like purplish color. And finally, we start not to see as many vessels anymore, and we start to see a lot of collagen left, and that's when we start the, CO2 or the fractional pico or the fractional erbium lasers. And another case, after 15 days, and each 15 days after each one of those assessments, and this is after 3 years of treatment, but you see that this improved significantly also. And we are using this method also to treat, ectropium, this deep fibrosis. Some keloids disappear, others improve, but, not completely disappear. You can see here, from, each 2 months you are seeing one of those photos. Final outcomes. And even some patients that we think we are going to have to operate on the skin, sometimes the skin shrinks completely. So some other cases, let me show you very quickly. This patient following one deep peel made, performed by a dentist of the skin, one of those people. And the ASAP also improves, the functional of the patient. This patient could not use the dental floss when she arrived. Some other cases. And then we start improving texture and pigmentation using the fractional and the pico collimated lasers. And it really improves the texture. And so I've already shown you. This is just for you to see after one session of pico how you can get better pigmentation and outcomes on pigmentation after the pico. I'm very proud of my pico laser, guys. It's really an awesome, device if you work with scars. And this is what the bleomycin does with microneedling after a month. You see that it actually improves a lot the pigmentation in the skin. And I just wanted to share this one photo. So I have this session at the AAD meeting. It's called The Art of Healing, Treating Keloids and Hypertrophic Scars in Higher Phototypes. And this is Dr. George Ruza. So my friend who actually co-directs the session with me, Dr. Alex Zhang from Cleveland, told me, you know what? I know the guy that made the comment on the New England of your study, the very first study. It was in 2000. And I'm going to introduce you. And then she introduced us. This is us together in the Chinese party. He said, Gisele, I'm here in a disguise because now he is a senator for the Republican Party. He's like, I'm not supposed to be seen here in the Chinese party. But anyway, so please don't take it, don't show that part of the story. But so Dr. Ruza, it was very emotional for me because actually, because of his commenting, I get this wonderful opportunity to work in Shriners Hospital with Dr. Hendon. So thank you very much.